All right, welcome everyone to documentation dismemberment. We're jumping into an outpatient case today with a procedure involved. So we'll see how the documentation is a little different and the coding is a little different for that. As usual, we have no disclosures. Objectives are the same as always. Same disclaimer there about no history review systems or physical exam documentation specifically required. So jumping right into the case from the HPI, I had a second to look over that. Pretty short. Yeah, there's Alcoa is a big time aluminum company. There's also an Alcoa highway in Tennessee, which I'm sure named for the aluminum company. Any thoughts on HPI?
What is chickweed?
What is chickweed?
Okay.
Where does it say if he's had before diabetes? What's contributing to this smoke?
But it sounds like it's getting better.
Yeah, so I mean, just based off the chief complaint, it's a little weird. Because it's really something in progress. It sounds like the patient's already taken care of, mostly on their own. Already have home health come out and see. But in terms of HPI, it didn't give you a whole lot. But if you don't need it, you don't need it. So not going to affect the billing of it. You might have any thoughts on how that API was developed? Only AI would get into that level of detail about Alcoa aluminum.
That's true. So that needs no
correctly and
alcohol.
capitalized.
There's alcohol.
Yeah, so what happened was home health order got put in on the patient. Came in here, got put in, like the phone call, generated home health order. Then you have to have a face-to-face. Most of the time, the patient got who. Most of them are. But you still gotta accomplish face-to-face so home health can do it. And while you got the patients, you do what you can. All right, so there's the histories. Quite a lot of problem list over there.
Diabetic ulcer of right great toe, and then venous stasis ulcer of right lower leg.
Not good.
Diabetic venous stasis. Using peripheral vascular disease.
Any questions about the histories, medications? Really? All right, so review assistance physical exam.
Yeah, phone numbers and.
Yeah, so I mean, I think
That's a good
this gets in this mirror. The thing is already healed before the patient ever shows up. So it's a bit of an awkward, we'll have to clean up home health.
I wish there was measurements. I would forget.
Right. I mean, if it's not open though, it's kind of a weird, like, what do you measure? If you trying to measure something that's healed, like not exactly a true measurements. You couldn't, I mean, from a wound care standpoint, you would have to have very precise measurements. Feel the wound worker. Not so much, and it's already healed. So you, guess you could probably guess and see what that means. The area is healed. I'm not sure that would get infection. So moving into assessment and plan.
It's good.
Any thoughts on that? Pretty.
I'm surprised it's not more in depth with the AI.
Well, none of that stuff got
Isn't
solved.
diabetic control here?
You know, the simple stuff
Yeah,
for the AFib, it's either rate controlled or it's not.
that's true.
Your vitals in your exam, there's not going to be a lot of questions you're asking, like,
Mhm.
is your AFib rate controlled? High blood pressure either controlled or it's not. Although I am surprised that the AI didn't put more hypertension full stuff in. Monitor your blood pressure at home, but sometimes it likes to create its own thoughts. On the assessment. It's just the standard stuff, monitor your blood pressure. It's just fluff anyway.
Not get any points for educating them?
No credit for that.
If it's uncontrolled though.
Still get points, that just affects your diagnosis. The chronic stable. All right, so that's half the rest of the assessment.
Let's see the procedure now.
Let's see the procedure now. All right, we gotta see the instructions first.
Jumping spider. Good bit.
Yes. Not, but around something.
Nice. He don't bite cheap.
Two spiders.
Anything else on the instructions? Be ready for the procedure note.
Mm-hmm. There's no permission.
No permission. You didn't get consent.
Yeah.
Or the person didn't get consent.
We got papers for that.
That was about to be.
Did you perform a timeout?
Only time I would take.
This does bring up a good point, because a lot of the thought phrases that people have does have like consent obtained, written, or used to. Not like necessary.
Not necessary as far as I know, to bill for the food. Legally, if you got a piece of paper signed, you actually don't need a, you actually don't need a consent sign. You need verbal consent. That's why they put all those. You're supposed to do it. But to me, when you get into timeouts, on it's going to be recorded. But I mean, if the patient's wide awake, like and you're sitting there looking toe together, are there scenarios where timeouts make sense? Obviously, yes. But I mean, in some of these scenarios in a clinic where you're trying to move, then
I mean, what are you gonna do? Call for wrong callus for this situation?
I
You
mean,
gotta go anyways.
I don't know. In theory, should it, by the book, should you? Yes. Do most people in clinic settings all that? But if you got all that as part of a paper process, then is that being a note? Oh, could be. Probably yes. I don't know of any dot phrase for a callus.
Sure, rising hand.
I mean, yeah, you have to build some sort of generic procedure statement and then just use the insert all of those stuff.
Tear down the carpet.
I think that's actually the CPT code. I mean, it doesn't take a lot to capture.
Cut down,
Tear down.
sliced down.
It doesn't take a lot to document the procedure, especially for a callus trimming. 1 to 2 minutes. Longer to go on the scalpel on that procedure. So now jumping into the medical decision making, which is all based on 1.1 guidelines with diagnosis, data, and risk. And so a quick overview of diagnoses. And then, of course, our definitions. We got this just mostly for reference to go back to if we have questions about it. So how would you, what would type 2 diabetes be classified as a diagnosis? Unstable, less specific, uncontrolled, not at go. Venous stasis ulcer.
Stable. It's not getting worse.
Right, this is a tricky one. Like I already. It's right, but it's healed. So
Still doing the current. I'm
Yes.
stopping there. So.
call it an acute uncomplicated because self, I'd say it's not sure it's self-limited, but still seems a little more than self-limited. Obviously, if it's some don't discount particularly. But I think
Where do we
acute,
find this?
I think if you go back and go with what an acute uncomplicated injury, it's a new short-term problem or risk. I think so. When we do that, especially in hindsight, it looks like an acute uncomplicated.
But when they get acute state, I feel like that definition was.
No, I see. It could be acute stable too. I agree, but it's resolved. I mean, By definition, that one said not yet resolved.
You didn't initiate a
I think you could argue, to me, it's acute uncomplicated.
You said, here's the one.
Low.
Yeah,
Yeah, you're still playing the low. Like, even if you want to call it a self-limit or minor problem, none of them get you beyond. If it was infected, or if it's draining, or you thought you were going to do antibiotics, or is out something else, osteo or something, that gets you. Right, none of that, by the time it's already healed, it's game over on that. So chronic AFib, obviously
Stable.
documented as stable, so chronic stable.
You refer the
Anemia. And anemia is not specified as to whether it's stable or not. Kind of a piece
You're not
of that
making
is, it's not changing anything, so it's therefore. Hypertension, chronic stable. Hypothyroidism, it's not stated otherwise, so it's going to be chronic stable. Cognitive impairment, it's not stable. It's anemia, chronic stable as well. So we're racking up the chronic stable. How many chronic stables?
but is it stable if they didn't tolerate their med? You put a med on it, they
The
failed.
impairment is
I know that, but he wrote,
Is that medication management or something like that? Maybe that's me. I think the diagnosis itself is stable. Med intolerance. Pilot. Yeah. You might get a code rotation. All right, and we got corns and callosities. Great ICD-10 code.
you can call it.
Callosities. Callosity just sounds so much better.
A moving
I
there.
mean, I wish I had callosities.
but if you, well, this one was like, get the operator on. Don't risk life or limb. It's also,
I think it's more of a chronic because in the scenario, it's recurrent callosities. Probably more of a chronic. I mean, obviously, this could go either way. Just depending on if it's a recurrent callus. If it's chronic unstable, it was in the histories, so it's an ongoing problem. But first time you dealt with it, issue. I don't know. Chronic unstable may bump it up higher than what it really is because that's kidney level 4. I'm not sure. Unless you trumped it up and said, you got diabetic at high risk. Peripheral neuropathy, and of course, it did have a history of ulceration. It's not explicitly called out in here. Probably could have been stated, but the thing about the corns and callosities is you're not. How does that impact when you do a procedure?
the reason why you did it.
That diagnosis, though, becomes pulled to that procedure and isn't so much a part of your E&M. Which is next, but it doesn't really count because the procedure was done without like there's nothing extra done to the corns and callosities other than the procedure. You really have to trump that, go out of your way to trump that up.
You order like survey or as
CeraVe
Or-
or Vaseline.
Lotions.
Sarah Van
Survey.
Trent. I thought you said survey, and I'm like, yeah. After velocities to turn in. Polar velocities.
Well, what else you gonna do to prevent?
You could, I mean, you could turn it into an eating, almost making it part of diabetes. Yeah, already talked about those steel toe boots at Alcoa Aluminum.
Yeah.
1975, so.
So if you'd have put this just under the diabetes part, corn and calluses, removed. This isn't gonna get you.
You got a diagnosis you need to diagnose. You still have to have that to tag it. But to get more E&M out of it, so it really had to have some impact. Yeah, if there was multiple ones. But at the end of the day, if you're dealing with this many problems, why spend the time to tie all that back in? You're managing all sorts of stuff. You already got the go home with that. And hidden up there. So what's the diagnosis level on this? Four. Yeah. And then what got us to the 4?
More than 4 chronic.
Yeah, the 2 chronic staples get you to the 4. So labs are ordered, if there's something done with them, so all that ties back in. And you can do most of that gets done without really doing any pre-work on the patient. Do their vitals, pop on some auto text, manage all that without everything else. So now in data, everybody remembers our level 4, we're trying to get 1 of 3 categories. Category 1, of course, is the any 3, a note, external notes, reviewing a test, ordering a test, on top of an independent historian. To me, if you could remember category 1, then category 2 is just remember, I mean, it's key to remember those categories and know those are the things that get you worked up. Not as important in this case because having some nice auto text you hit the buzzwords that say independent interpretation. Images, or always having a nice little auto text about discussing your provider. Appreciate Rex. It's the most unappreciated piece of documentation, in my opinion. Hospital useless words. Doesn't get you paid anything. Takes up a line.
Mine's already there because they're.
Right.
So it's just another 2 words.
So then put a colon and
Or you can just put discuss.
Cardiology consult, colon, and then update it. Or just keep their plan in there. Sidebar on not outpatient. But it does happen. I mean, you get stuff done and do an MRI and the radiologist just, hey, it's just happened. Hello from radiologist telling you about finding on MRI. If you happen to see that patient that day, that in your opinion somewhere. At level 5. At least get you to category 3. All right, so now breaking down the data of this. Now we're gonna flip through, everybody's seen what we've ordered there. CMV, A1C, CBC. And there's DSH. And a lipid panel. So how many category ones do we have? We got five separate orders. Those liver tests. Category 2, nothing. Category 0. Category 2 is 0. Category 3 is 0. So not much exciting there. So what would be the data level of this?
You only have to have one of the three things,
One of the
and you
three.
have to have three within category 1.
Oh,
You got it.
It only takes 3 in category 1. I'll get you in. In order to get to 5, I gotta have 2.
Two of the three.
Get to level 3, you only need 2.
Or an ind-
Or any of the other
interpretation.
category, any of the other categories. It's 3 doesn't. 3 is just purely category 1 and independent. And then it's so really what category 3 does. I don't understand why category 4 and 2, why they made low have its own separate category for the independent historian. Why didn't they just group it all together and just say you needed one, just needed to meet this category, keep it all together? I don't know why they did it. On the table here because not useful. But anyway, you're not calling me that. Maybe Elon's gonna call me and see how we can make this table more efficient. So yep, definitely level 4. All right, so from a risk standpoint,
Need management or level 4.
yeah, so most of the time, your level 4 in the clinic is making sure you've got some way to capture that prescription drug management, just reviewing the minutes actively, having a statement that actively says
You mind to search your risk factor? What, Taylor?
and see, that is a piece that comes into this. How much do you have to document to capture risk? Repairing down a callus.
What if you made an ulcer?
Right, that's the biggest risk here is that you cut the patient's diabetic. Just where a risk benefits statement in the documentation. Close that up. We've already talked about prescription drugs, so rivaroxaban get you to level 4 there. We've statement about continuing hypertension meds, so level 4. So overall, we talked about this. We can also read the way it's documents the decision. If you trumped up some of the bleeding stuff and this and that, you could get that to level 4. But you're not really even using. It's one of those, a callus to me is going to be hard. You really got to play that up in a callus.
But if you only get the callus, you already have it. Otherwise, all of the contract.
Yeah, I mean, I think that's one of those where if you trumped it up, the coders would have to go with you talking about all the risk in the grand scheme of it. I don't think most of them start with callus. Depends on who's holding the scalpel, maybe. I did a risk, and that's more the bearer of the scalpel. And hung up on when I tried to call. So yeah, definitely level 4 on that. But yeah, you could, if you needed to try to get that, but you would really have to do, you'd have to work, craft your documentation really well. To level 4 EV now, plus the procedure. Because you would have to talk about all the risk and all this. I just don't think it's not one of those things in your back of your mind going, wow, I'm gonna go level 4. Technically, you could do it. It seems a little on the fringe. It seems a little on the fringe to me if I was really trying to push that.
Number 7, you couldn't tolerate. Wouldn't that be a bit?
Yeah, I left that off the phone. I would say that would catch. I think that would have got. Other stuff.
How many level 4s within this section do you need as a level 4?
You just got to get one out of the whole risk section.
Everything else is a 3.
So
if just rivaroxaban, you need one of those. Which makes the whole risk a level 4, no matter whether that's involved or not.
even if you didn't prescribe it that day, like I said, they had refill. You would continue. You're good.
As long as you got a good auto tax that says that's why I think the system.
I don't think it's got a better check mark.
Do you have to specify the meds? Or if you say continue, that's per med.
You've got the medication list. And you can say that. Making a statement that says, making a statement that I have acted. Actually. And I know coder's going to go with that.
Their medications on the side of the paper. Their medication, that should be what you continue.
Should be, but there's nothing that shows whether you didn't need it. You could do this without, you could do it, but you could not take med records. What's happening in the system? I think it should, to me, the system should stamp that. I don't understand why they don't have that built in. That seems like important.
You do it to your cash return.
You automatically feed it in. They deal with that. It should. Then you wouldn't even have to do this other stuff. Probably. I don't know. Because then they also don't love generic statements. That's why I do this one and put it in the problem. You just put in a blanket statement that says, hey, I did the med. Hide the diagnosis. I'm sure it's one of these where some coders will probably let that go, but I think coders should be understand.
If you put just continue home meds per med record,
Yeah,
have to say,
I
like,
cleared
continuous
that
med.
with our coding team here. As long as it's assigned a diagnosis.
Specify which
On the inpatient side, ED, from a TVL standpoint, they really push you actively. Make a statement in the office. Stuff's more, stuff's changing. You're not refilling all of it. You're not actively doing it. And you're seeing these people once every 3 months. In the hospital, life or something. You really do. But you're still letting it continue on. I think it's just the inpatient versus outpatient mindset from the coding. All right, so our coding summary, so we got level 4s across the board. Obviously, final EDM code's gonna be a 924. What about the procedure?
Modifier.
Amplifier.
I like that.
We're going from
Fire.
coding to rock band. Oh, procedure coding, CPT coding. It's CPT codes for procedures are independent. EDM coding. So actually, EDM code requires modifier. I think amplifier, sounds cooler. Velocity versus callus. EDM code modifier, in order to bill for the EDM code on the same case. Some common modifiers. Modifier 25 is in this scenario. It's important that CMS significant separately identifiable evaluation measures if you're doing a procedure and you're trying to problems, on the procedural code gets solid, which is where that diagnosis gets tied up. It's already pulled the diagnosis. So you have to justify. You want to tag that same diagnosis to your info. You have to justify why you're doing something. It's significant, identifiable, not just for the patient, but for that problem. Sometimes, especially if they're Catholic. If you were doing something like an injection and you were having to get X-rays or physical therapy or manage a shoulder issue, you got a rotator cuff issue, injection, you're also sending for physical therapy and you feel like diclofenac. Those are separate identifiable management conditions. So you could use the same diagnosis for the MPT and the ENT. But you would capture all that in the documentation. Had this callus had an ulcer underneath it, but you're going to have a different diagnosis then because you're going to use so the modifier 50 is when you do bilateral procedure. So if you did left knee and the right knee, modifier 50. And if modifier 51 is if you do multiple distinct procedures in the same encounter. So if you did like a shave and a punch, those get modifier. So you're flagging that in the background. I deserve to get paid for all of them. It's more of a procedural thing on the back end for the coders and the insurance. It's more about the insurance companies at this point. Just to raise a flag and say, hey, so to pay this, you got to put it on there. Or they'll deny one. Part of the game. So getting back to the procedure, so it's actually the CPT code for that is a 11055, which is pairing skin lesion. Yes, pairing is the proper word, even in the CPT language. And there's the definition of that I found for that. Using a sharp instrument.
Could have used a paring knife.
I mean, we could have gotten a pocket knife.
Pocket knife.
All right, so now if we go back to our coding summary, we've still got all those fours. So then it's a 99214 with a modifier 25 attached to that. And your procedural CPT is a 11055. And so then how does that translate into work RVUs? Because that's really comes down to for how much does the provider get paid. It's 99214, the 11055. 99214 is 1.92. 1055 is 0.35. So, I mean, a pair down one callus. It's not an impressive amount, but
Well,
anticipated that question.
really, you're getting paid to take those risks.
Yeah, so I mean, so now you've at least like with that little procedure, turn forward. Very quick procedure. So to me, a 4.5 here is probably from a time standpoint better than trying to do a bunch of fives. Fives are going to suck up a lot. Every time you go and get X-rays, call somebody to get admitted, and do all the things that typically gets us to a level 5, takes a lot of time. And so doing very simple procedures as part of your standard E&M visit. I had 5 minutes instead of the 15, 20. 5 at least.
When you had time, if you could talk while you're shaving his callus.
Your blood pool.
Yeah, I mean, you could do it.
Good. I mean, now with AI, listening to you when you're doing the whole, you can probably do.
It's a bunch of callus before you start.
Especially if you've got proactive nursing, right now there's a big callus things in your stuff. You're able to just have to go find your own stuff. Yeah, I mean, we do lots of little things, punch biopsies, these shoulder injections. I mean, you're going to see that in practice. You really could probably already have all that going while you're doing something else. If all that gets set up for you, you're just going to roll through. I didn't look up RVUs for stuff like injections, but I would say they're much higher than a 0.35.
You know what toenail clippings were? You just did them during your diabetic exam. Toenail, shave a callus.
I don't know. My lookup tool that I use, and I got another cup. Right on the fly. There's not a lot of places that want to just freely give away a chart. There's a nice APC website. You just plug in your code. It's out there. You can actually put in left column will be the codes, and the right column will be like how many. Stick in one and hit or whatever, and he'll spit out how many RVUs, or you can put in more codes. We'll report on how much each one is worth. So it's just something a tool to know about. If you're thinking about how much time does it take. I do think that's very simple procedures, and the callus is easy to do. 0.79 for shoulder, knee and shoulder injections. I mean, that's actually putting you right at the 9.5. You can do it. Plus, you don't get paid. Really makes more money. So if you're in a setting where you're actually, some of that flows back to you because you either own it or you're in some of these unique contracts where that somehow spins back to you without violating the laws. It works, but I mean, it's much easier to get a 99214 with a high bar procedure if you I'm not doing 5s are pretty taxing usually because you're having to deal with so much.
Say you did a callus on both feet. You get 2 of those CPTs.
No, there's a I think it's a 1105. Guessing.
I don't think it makes you.
That's why I was wondering how to adjust your.
I think it's a half. You two together, you get 100% of the person. Roughly.
They're not messing up the room. They're wiping.
So you
You're
get
using
the
the
same
same
tool.
scalpel, you're using the same scalpel. Still, you're talking about 30 seconds and another two or so. Yeah, I mean, if you're gonna start taking calluses down, you might as well. It'll be at least two.
You don't want to take on that risk.
Yeah, you put it, bring it back just for that, all you're gonna get is the 43 back.
Restart.
People who do that, if you want to get all of it.
Patient's not gonna come back every week.
There's the references. Any further questions? Well, we've got this recording down now.